So I'm going to pass it off to Robert from now on with the presentation.
All right, does everybody see my screen?
Yes.
Excellent, thank you. All right, so without further ado. Hello, everybody, and thank you all for taking the time for being here today. I'll be talking about the development of a new technique in our lab for the estimation of fat volume in plastic surgery with the guidance of my supervisors, Dr. Gilardino and Dr. Hamlin. Today's presentation will have the following rundown: the rationale and background, followed by some methods, results, and finally the discussion along with the future works. So to begin, adipose tissue plays a fundamental role in plastic surgery, extending from fat extraction via liposuction as shown in the image below, or for the transfer of vascularized flaps for oncologic and reconstruction purposes, and even for burns following a traumatic injury. Procedures involving fat manipulation, such as liposuction, contain a degree of subjectivity mainly guided by the surgeon's visual or tactile perception of the underlying fat. This acquired sense dictates procedural behavior where complications commonly result in the body contour irregularities and, in very rare cases, potentially lethal pulmonary thromboembolism due to inadvertent violation of the vasculature. There currently exists no reliable gold standard to measure objectively fat depth and volume in real time, and to assess changes in these measures, which are key to accurate manipulation of fat tissue. Surgeons currently estimate the required fat volume for operative procedures by visual and tactile sensation, as I said earlier. With no practical and objective technique for measuring fat volume, there is a gap in the current literature regarding objective measurement procedures that incorporate subcutaneous adipose tissue, also known as SAT volume, in an intraoperative, rapid, dynamic, and cost-efficient approach. A series of reviews were conducted to elucidate current literature on ultrasonography technique regarding adipose tissue measurement, objective volumetric quantification of reconstructive flaps, and quantification of liposuction results. As a summary for these reviews, they suggest three main key findings. First, that ultrasound can be used as a method for accurate and efficient quantification of subcutaneous adipose tissue. Second, that no reliable gold standard exists in volumetric quantification. And lastly, there is a need for objective and quantitative assessments to measure changes after fat-based procedures. So, ultrasound was our chosen device of interest because it provided us with that dynamic, rapid, and intuitive intraoperative assessment we needed, unlike with the extraoperative and time-consuming MRI or CT. Satmap was then created. It is an in-house developed computer-based application that utilizes ultrasound subcutaneous adipose tissue measurements to generate a heat map and estimate the underlying fat volume. Liposuction was chosen as a surrogate procedure for assessment and standardization of fat measurement, since ultrasound measurements can be correlated readily with extracted volumes of pure strained fat. Additionally, the surgeon can obtain multiple ultrasound images from the same patient in different regions. By increasing the yield of measurements under various conditions, more clinical data can be acquired. The research is Institutional Review Board approved for human clinical trials and are currently ongoing as well. This will allow for the continuation of the software's accuracy evaluation and development. That brings us to the hypothesis. We believe that presenting real-time fat volume estimations and 3D volume profiles with Satmap can promote better surgical planning regarding key surgical matters such as improving surgical efficiency, reducing complications, and reducing revisional surgeries. In addition to that, such a tool may help surgeons to more accurately plan, measure, and execute the transfer of fat tissues, and in the process optimizing patient conversation, expectations, and ideally outcomes. To achieve this, two major objectives must be attained first. We must evaluate the accuracy and practicality of the pilot software in a clinical setting, and the introduction of an automation tool is in the works for processing digital ultrasound images within the pilot software, which would allow for various features such as tissue depth to be instantly analyzed without the need for human registration. In this pilot study, a total of 15 participants will be selected to evaluate the accuracy of the pilot software. The study will be conducting trials at plastic surgery clinics associated with our academic institution who regularly perform surgical procedures involving adipose tissue. Patients will be selected based on their procedure of choice, namely if they elect to undergo standard liposuction and do not opt for any non-invasive techniques of lipolysis. Furthermore, patients with scars or previous surgical procedures performed in the areas of interest will be excluded. Although the ultimate goal of this project is for the complete automation of this technique, it has not yet been achieved. However, digital ultrasound images are still processed very quickly in the order of 2 to 5 minutes per patient. The procedure is as follows. The operator takes the ultrasound scan and determines immediately on the device the fat depth by labeling the skin fat interface and the fat muscle interface as shown on the figure on the right. From there, the ultrasound images will automatically display a depth value, and this is then transferred within our program to estimate the fat volumes. All of the scans are taken by an attending physician with extensive experience with ultrasound devices. Speaking of our program, Satmap Dashboard, this is the first version of the current functional dashboard, which incorporates patient information and measurement inputs. The beauty of this method is that such a website can be accessed from any device, anywhere, which provides a nice practicality to the method. In addition, the dashboard provides a sense of partial automation, with the last part of the automation missing being the automatic determination of fat depth using machine learning inputs. Replacing that currently is a table where all values are inserted manually, and then using our equations, we'll estimate fat and generate our 3D figure. Once the graph is generated, this is the current 3D heat map, which is still in development. A few key features. The heat map presents a depth scale on the right-hand side, where purple or darker is superficial, and the yellow lighter shades present more deep regions of fat specifically. The large purple plane underneath was extended in this version specifically to represent the skin. The top left of either figure presents always the superior and posterior portion of the flank in this case, and it was taken in a vertical fashion. A new model is in the works to make it look more lifelike and ultimately be able to display true separate sections of skin and fat with better color coordination and thickness representation. Now for the most exciting part, the preliminary results of fat estimations compared to the true lipoaspirate collected post-liposuction surgery. The graph here presents a blind Altman plot, a popular technique used to assess two quantitative methods of measurements, our ultrasound estimation technique versus the gold standard of true fat collected in the OR. We assess the agreement between both by measuring the mean difference and construction limits of agreement at the 95% confidence interval from the resulting differences. For the first 11 patients and 25 data points collected thus far, 24 out of 25 of the measurements fall within an agreement of 95% compared to the gold standard. An interesting note is that one could suggest that with increasing liposuction volumes, a larger deviation from the mean is observed. However, it is too early to make any concrete assumptions yet, and more data points are required. Another method to represent this, but with less statistical significance, but rather a very pleasant visual representation, is a plot of the percent differences from the actual collected values. This graph compares the original Satmap ability versus the new one I constructed this year. Here we see in orange the true value of lipoaspirate removed from patients, which is noted at 100%, and below in green, how close our estimation was to that true value with the new method. The same applies to the gray values, which represent the old method. Say we take patient number 3, for example. Our true value of 75 cc removed would represent 100%. Now take the new method estimation, we find 79 cc, which roughly estimates to 95% agreement. As for the old method, about 110 cc was estimated, which equates to a little under 70% agreement. On average, with the data we've acquired so far, the new method is only around 8% average range away from the true values compared to 31% for the old method. Preliminary testing of the software demonstrated a user-friendly and intuitive application with encouraging results. However, the graphical representation could still use some tweaking to make it easier to comprehend and apply directly. Following initial inspection of data, the large resultant volumes potentially seem to be slightly more variable from the median, yet the data also suggests that at lower volumes, there may be a stronger agreement too. This can only be ascertained after testing the software completely in the clinical setting and finishing the trials. From there, we can take all the measurements and patient details, compare them against the true volume of lipoaspirate extracted during liposuction, and subsequently allowing for appropriate calibration and adjustment of the software. For the remainder of this project, the future works is split 4 ways. First, with the new software running at greater than 90% agreement currently, conceptually speaking and the theory behind the method, I believe we are near the finish line with only small tweaks necessary to fully adapt to different liposuction practices. This brings us to the trial. As of this week, we finished recruiting patients for our study. All is left is to compile the final patient analytics and perform the statistical analysis. Regarding the Satmap Dashboard, the focus will be on improving the aesthetic and practicality of the website, but more importantly, also incorporate the complete automation of the method. Lastly, to reduce the potential of inconsistencies between ultrasound users, we are currently developing a proof of concept design for a force sensor integration within our ultrasound design to minimize inter-rater differences in ultrasound use. On that note, thank you very much, everyone.
Perfect. Thank you very much for that very illuminating presentation. If anybody has any questions, you guys can either speak up and unmute yourselves or drop it in the chat. Okay, I actually have a question I can start off with. In the pilot study where you're recruiting 15 volunteers, do you estimate that there will be a variability between, let's say, people of different sexes as far as how well the tool will perform, or you expect it to be relatively even?
Thank you for your question. And I think it's a great question and something to think about, because at the end of the day, what's great about our tool is that it shouldn't really matter. Fat can be differently, how should I say, represented under our skin, and we have different variations, fat lobules, and of course we can have different depth, different, how should I say, methods of it being presented. However, at the end of the day, ultrasound scans are very direct. All they scan is the echogenicity, and that's all we really take in as a measurement. So depending whether there's any sex or different morphologies, anything of the sort, it shouldn't really matter at the end of the day. Where it does matter a little more is on the operator technique. Ultrasound is quite a finicky tool, especially if you press a little too hard, you'll have different resulting volumes. If you press too little, you might not see very well. And that's where the variation really occurs and is difficult to monitor. So we have established a protocol, which I haven't presented here, but a protocol to try and maintain a standard operation every single time between all patients in any way. And so hopefully that will mitigate those concerns. And so far it seems to have done so. And hopefully if we do continue with more trials later on, we can prove that as well.
Perfect, thank you very much. Okay. Now we'll be moving on to the prof presentation.
So thank you very much, Robert, for that wonderful presentation. So our next speaker is Dr. Lawrence Lee. He's an assistant professor in colon and rectal surgery, Department of Surgery. And so his main specialty is clinical interest related to the treatment of colorectal neoplasia and inflammatory bowel disease. In particular, Dr. Lee specializes in advanced minimally invasive and endoluminal approaches to the treatment of colorectal disease using all sorts of wonderful and exciting approaches, such as flexible endoscopy, transanal endoscopy surgery, and transanal total mesorectomy excision. So his research basically includes health technology assessment and comparative effectiveness research for surgical technologies and innovations, with emphasis on the practice of colorectal surgery. So he has other areas such as perioperative assessment and functional and patient-reported outcomes after major abdominal surgery. So he completed his general surgery residence at McGill, during which time he completed a master's degree in epidemiology, and this was followed by a PhD in healthcare economics. He then completed a colon and rectal surgery fellowship at Florida Hospital in Orlando. He is the recipient of the SAGES Research in Training Award, amongst other awards that he has obtained, both national and international awards, and scholarships for his research and clinical work. So he is a fellow of the Royal College of Surgeons of Canada and a diplomat of the American Board of Surgery, and holds a specialist certificate from the Collège de Médecins de Québec. So it is my pleasure to welcome Dr. Lee, and the title of the talk is The Evolution of Enhanced Recovery Pathways for Colorectal Surgery. So Dr. Lee, please, it's all yours.
Great, thanks. Thanks, Dr. Mwale. It's like too long of a bio for me, you know? We can blame Micah for that one. All right, so anyway, like I said, thank you for the kind introduction. Well, we'll be talking a little bit today about how we've been really kind of our evolution of enhanced recovery pathways for colorectal surgery here at the MUHC, and specifically some of the more exciting things that we've been doing with same-day discharge and as well as digital health. So these are my disclosures. They shouldn't be too relevant, or it shouldn't affect the talk too much today. So I'll give you a bit of history, because I think looking at the participant list, I think everyone, the vast majority of people here are master's students and not necessarily clinicians. But kind of when you look back at perioperative care after kind of colorectal resection, what we call traditional care, it wasn't great. All right. So after surgery, and this was mostly done open, patients had nasogastric tubes, which is kind of like a tube we shove down people's nose that drains out the stomach. They had enforced bed rest after surgery. We kept them fasting until their bowels started working, and then we used a lot of opioids for pain control. This is some random picture I took off the internet, but this is not unlike what a lot of the patients looked like when I was a medical student back in the 2000s. And even for people who kind of had an uncomplicated post-operative stay, so they had colon surgery and nothing bad happened to them per se, they still stayed in the hospital for about 7 days. So this is kind of how things were going up until about the 2000s, mid to late 2000s. So in 1995, Henrik Kellett, who is known as the godfather of enhanced recovery or fast track surgery, published a perioperative care pathway, which is very groundbreaking at the time. But he didn't really invent anything. All he did was looked at the best available evidence for all phases of perioperative care. So both before surgery, during surgery, and after surgery, and looking at all the interventions, looking at what was the best available evidence, and then kind of implementing these in one single package. And he first published this in the Lancet in 1995, and it had only 6 patients, which goes to show how things have changed in the publishing world. If you had 6 patients now, I don't even think Lancet would allow you to submit any. The editorial manager wouldn't even allow you to submit. But this fast track was a huge departure from what people were doing at the time. I won't go into too much detail, but basically kind of through all phases, both pre, intra, and after surgery, there was significant changes to what was essentially surgical dogma. So in the past, we used to keep people fasting up until really the time of surgery, starting about 12 hours before, because we used to think that if you gave them food, they would aspirate during induction. But now we're giving clear liquids up until about 2 hours prior to surgery. We've changed our methods of pain control. We basically feed everyone very early. So instead of waiting for patients to pass gas, we're giving them clear liquids immediately after surgery and then letting them eat on the day after and taking out all of the tubes and drains as quickly as possible. So in the 2000s, he published kind of his like first large series of 60 patients, about 74-year-old average age, of this kind of like open colon resection with postoperative care, which he called fast track at the time, and kind of included some of those interventions that I had just shown. And he showed that this was feasible, didn't have any increase in complications, and his length of stay went from about 7 days, which was kind of like standard at the time, to 2 days, without really any increase in readmissions. So since that initial kind of the 1995-2000 publications, there's been a lot of literature showing the benefits of enhanced recovery in a variety of procedures, specifically within colorectal surgery. When you start using enhanced recovery compared to traditional care, we can decrease our length of stay by about 2.5 days. The overall complications decrease. There's no increase in emergency department or readmission rates. And because patients are kind of staying less, shorter time in hospital and having less complications, obviously the healthcare utilization is less and patients tend to be more satisfied. So setting the stage now, that's kind of a bit of a brief history of what enhanced recovery is. So you kind of know what I'm talking about. Here at the MUHC, we've been using an enhanced recovery pathway for colorectal surgery since about 2008. We've since kind of, from this initial highly selective approach in 2008, this protocol has undergone many different iterations and improvements over time to now kind of obviously everybody is pretty much on it. And we've applied a lot of these enhanced recovery principles across different specialties and procedures. Within colorectal specifically, our target length of stay is 2 to 3 days, and about 2/3 of our patients are discharged within 2 to 3 days. Now, things evolve with time, and even though enhanced recovery was a big departure over traditional care, it's been around for almost like 15-20 years now. So what's the next step? Our target length of stay is 2 to 3 days, yet we know that kind of a lot of people stay in hospital for no reason, anecdotally. So a couple questions we asked ourselves is, although we're quite happy with about 2/3 of patients meeting our target length of stay, why do they really even need to stay in hospital? And what can we do to kind of further improve this? Looking at some of the available data, we see kind of looking at why some of the main reasons why patients are still in hospital after laparoscopic colorectal surgery. And you can see that not passing gas tends to be the most common reason across postoperative day 0, 1, and 2, with a bit of pain and mobility issues afterwards. So, we know that a large proportion of patients after laparoscopic colorectal surgery really just stay in hospital waiting around to pass gas. Even though, we've done quite well with enhanced recovery, there's always room for improvement. And so what is the next step? We've gone from traditional care of about 7 days to enhanced recovery to about 2 to 3 days. And then now we even have to ask ourselves, like, do these people who stay 2 to 3 days even need to stay that long? So kind of the next barrier would be outpatient surgery, which is kind of, initially people think that you're crazy to suggest that you could send patients home directly from the recovery room without having to stay in hospital at all after laparoscopic colectomy. But that is what we did. And it wasn't necessarily kind of out of nowhere. There were many several issues that we had to look at prior to kind of implementing this protocol. So first, these are the 3 main things. We'll go through each one of these individually in detail. So first, is it safe to send patients home prior to kind of return of bowel function? Are we able to control their pain without giving IV medications, which obviously can only be given in hospital? And then thirdly, are we able to make sure that they're not going to like go home and die or have some sort of complication at home without us knowing? So when we look at the first kind of aspect of whether it's safe to send patients home before they have return of bowel function, again, keep in mind that back in the day, if you look back 20 years, we wouldn't even consider feeding people until they started passing gas. So now we've kind of evolved all the way to sending them home without them having pass gas at all, right? So this is like a huge change in our management. When we look at our own data, ileus, quote unquote, which is kind of which is a fancy way of saying a delay in return of bowel function. It only happens in about like 18% of people. And so the vast majority of people, you really don't have to do very much to them, right? They just do fine if you leave them alone. And this is shown not just by us, by many different people. If you look at a collaborative in Europe of almost like 3,000 people, we know that being able to tolerate liquids or oral intake within the first 24 hours is usually associated with good outcomes. And subsequently, obviously, conversely, if you don't tolerate, that tends to be a bad thing. When we look at, we did a study here at the MGH last year, about 200 patients. And we looked at whether or not they were able to tolerate liquids within the first postoperative day. So again, that tends to be that's part of our pathway. So of the people who were able to drink at least 300 cc's without any nausea or requiring any medications, 70% of these, of everyone tended to tolerate clear liquids on day 0. And I won't go too much into this table, but suffice to say that if you're able to eat and drink couple hours after surgery, you tend to do just fine, all right, without any higher risk of complications. And not just shown by us, this is shown across many different centers. This is another European study showing that of the 10% of people discharged prior to return of GI function, that there was no real increase in complications. A recent study out of Texas, I think, Texas, MD Anderson, they sent patients home with telemedicine follow-up on post-op day 1, even if they haven't passed gas, and they did not show any increase in complications. So basically, again, looking at the GI function problem, which tends to be what most surgeons are concerned about, is that GI recovery is really uncomplicated in the vast majority of patients. Like in the same vein, most of the time, even if they don't necessarily have kind of a fully uncomplicated course, you can kind of leave them alone. You don't really have to do anything for them. It's what we call kind of benign negligence. And we know that people who are able to drink within a couple hours after surgery tend to do quite well. So the second issue that we wanted to look at is whether we would be able to adequately manage pain after surgery without having to give some of the medications that can only be given in hospital, which is either patient-controlled analgesia. So that's a little pain pump, pain pump that patients kind of press that little button, you get an IV shot, a sub-Q shot, sorry, or if they required intravenous opioids. So a couple ways that you can decrease pain, or at least manage pain better, is that kind of choosing how to make smarter incisions, right? So you think that, okay, in surgery, we have to make incisions, obviously, but it's not one size fits all, and there are different ways to do our procedures, and as well as kind of different medications that we're able to give. So when you first look at what type of incision to make, for the longest time, everything was done through a midline incision, even in laparoscopy. So even though you're doing kind of using the camera and the small incisions, you would still have to make about a 5-centimeter incision around the belly button, a vertical incision around the belly button to be able to actually physically take out the colon. However, we know that if you make that incision off midline, so instead of a vertical incision centered around the belly button, you make a horizontal incision, kind of like a C-section scar or like an old appendectomy scar, that these incisions have much fewer wound complications and, importantly, much less pain. And we've transitioned our practice into doing that. So for our left-sided colectomies, we now do a Fannin seal, which is kind of like a C-section scar. This tends to, our average length is about 6 centimeters, give or take. And for the right side, we've now transitioned to doing intracorporeal anastomosis, which is kind of a fancy way of saying that we do basically the entire surgery with the bowel connection inside the patient's abdomen. And then we only make a very small incision to extract the colon that is actually removed. And this, again, has been a big change in our practice over the last couple of years. And by doing so, we've changed from doing a very painful, ugly incision at the midline to these what we call off midline incisions that have much fewer wound complications and much less pain. And kind of there have been a lot of studies showing that these incisions are just much less pain. We are able to give much fewer opioids. Importantly, when we looked at our own data again, right, because you got to measure your own outcomes to know whether you're doing a good job or not. When we went from extracorporeal, so that is kind of a vertical midline incision for specimen extraction, and doing all of the connection on the outside and transitioning that to a fully intracorporeal anastomosis and being able to do an off midline incision, we were able to decrease the amount of morphine that we give for patients by almost 2/3, which is in and of itself kind of less opioids tends to be better for a variety of reasons, better for bowel function and decreased risk of having opioid dependence, which can be a big problem. We've also changed the type of medications that we use for pain control. So in the past, again, about 10, 15 years ago, we used epidurals and patient-controlled analgesias even for laparoscopic colectomy. And now it's really gone towards what we call opioid-sparing analgesia and as much oral medications as possible, with this big emphasis on anti-inflammatories, such as things like just Advil or Celebrex, as well as regional nerve blocks. So over the last couple of years, we've started doing what we call transversus abdominis plane blocks with kind of very standard medications. And in this, you can see a little video of here, we're trying to basically freeze all of the nerves that supply the abdominal wall, all the sensory nerves. And this is when we either can do it under ultrasound or laparoscopically guided here. And we basically try to infiltrate the plane between the transversus abdominis and the internal oblique, and thus freezing all of the nerves in those areas and providing really good pain control without having to give more medications. And when we look at our data, pretty much patients who got tap blocks, about half of them didn't require any opioids on post-op day 0, which is actually very eye-opening. Because we used to give opioids for everyone all the time, and about 30% on day 1, 45 on day 2, and almost more than 2/3 by day 3 didn't require any opioids, and all we were able to give for pain control was Tylenol and Advil, which obviously can be taken at home. Like I said before, the less opioids you give, the better and faster your GI recovery tends to be. So just by moving away from the midline incision and using tap blocks, we decrease our opioid consumption, improve our analgesia, our pain control, and as well kind of decrease the amount of opioids that we give. Kind of in summary, we've gone to smaller, better, and less painful incisions with time. We've started doing surgeon-administered tap blocks. And like I said, the less opioids that you're able to give, the less postoperative GI dysfunction you'll have. And lastly, one of the things that we felt was really important in order to be able to send patients home from the recovery room is how will we know if they're doing okay once they go home, right? So we can't just say, okay, we can't just basically throw them out of the hospital and just say, we'll see you in 4 weeks. And there have been many, many studies at the patient experience after discharge. And a very common theme for all patients is really they have a lot of concerns about access to kind of their healthcare provider information if they have any concerns or complications. So in the past, you can imagine that if you had surgery and you felt that your wound looked funny or having pain that it was worrying you, if you couldn't contact your doctor or kind of an equivalent healthcare professional and you got really worried, you'd go to the emergency room. And that resulted in patients kind of like 20% of patients going to the emergency room and kind of just waiting around for 12, 14 hours and kind of having no issues whatsoever, which leads to a lot of frustration and a lot of healthcare resource waste. But luckily now with what we call the mobile health revolution, there's like a bazillion different apps that are available that you can install on your smartphone, and which will improve this post-discharge communication between the physician and the patient. So we here at McGill use something called CareSense. There's nothing specifically better or worse around this one. It's just the one that we decided to use. And in this, this is kind of a new intervention that we now, for everyone who has a smartphone that undergoes colorectal surgery, we install this app on their phone. So within this app, we include our patient education booklet. So it's actually, and I won't go into detail about that, but this was years and years of development and refinements where we made information available to patients that was at a 5th grade reading level, and kind of went through all the common scenarios about surgery and after surgery and potential complications. And as well, once they left the hospital, they were given through this applet, kind of a daily 5-item, what we call virtual rounding questionnaire, really focusing on pain control, bowel function, ability to tolerate oral intake, and things like fever. All right, and also most importantly, it had a HIPAA-compliant patient-physician communication feature. So it's basically just like a fancy chat function, okay? And again, I don't know why I need to show this to you guys, because I'm sure everyone here knows what a chat interface looks like. But basically, patients are able to ask us questions, and they'll either have a nurse, the physician, or another healthcare provider answer them. So we first implemented this mobile health phone application, and just by using this app, we were able to decrease the number of preventable ED visits, right? So, there's going to be some people who need to come back because they have a complication, but the idea is trying to prevent people from coming to the emergency room for issues that can be managed either remotely. So if it's just a simple question that can be answered, or if it's something that can be seen in clinic, it tends to be a better use of healthcare resources. So we were able to decrease these unnecessary ED visits by almost 2/3. And as well, we decreased our length of stay because we were and this is mainly because we didn't have as many people come to the ED and get readmitted. And one of the important things that we noticed using this phone app is that patients were actually really good about telling us when something was wrong, right? Because we were concerned that patients, even if they had an app, like they wouldn't use it and kind of just show up to the emergency room kind of dead or like near death. But all the complications, all the bad complications, at least in this initial kind of pilot study that we did with about 100 patients, we found every single major complication was actually identified through an app-based interaction, which was very kind of satisfying for us. Patients also really liked the application. It was very easy to use. Again, nothing's, but they all tend to be the same, and they all tend to be pretty idiot-proof. And importantly, about 90% of patients who use the app felt that the app improved their ability to communicate with their surgeon, which kind of has always been an issue. All right. We did a little qualitative analysis looking at we are interviewing patients who use this app. And a very central theme in the feedback was that patients felt more secure after their discharge because of the ability to easily communicate with their provider. So this is kind of just like a representative quote: "Fantastic tool, especially to communicate with the surgery team. Very useful in the first day after surgery. Had some small complications after surgery and was able to communicate with the surgeon and got very positive feedback that was helpful in understanding the situation." And this patient did not have to go to the emergency room. And kind of anecdotally, we all know in the past, this specific person, which I won't kind of go into more detail about, would have in the past had to go to the emergency room. So in terms of using a mobile health application, we showed that it was very effective in improving patient-physician communication. It was very easy to use. Patients really liked it. It was super useful for post-discharge monitoring. It prevented unnecessary ED visits. And importantly, we were still able to recognize through app-based interactions, abnormal post-operative courses, and get patients into the hospital quicker than they probably would have in the past. So again, kind of going back to the initial 3 major questions that we had prior to kind of implementing our same-day discharge. Was it safe to send patients home before them passing gas? And yes, we basically showed that. And a lot of time, it's safe. And even if they have a slight kind of uncomplicated course, you really can leave them alone. You don't have to do very much. Are we able to manage their pain? We showed that by using better incisions and kind of tap blocks, as well as kind of sparing opioids, we were able to control their pain quite well. And if we're able to monitor their kind of progress remotely after discharge through our mHealth app, this was safe and feasible, and patients really liked it. So kind of putting this all into context based on the data for these 3 items, outpatient colectomy should be safe and feasible. This has been done before prior to us. So in France, and a couple years ago, they published their series of 157 patients, kind of same inclusion and exclusion criteria as us, more or less. But one major thing that they did, which kind of is a little bit crazy if you think about it, is that they actually had a home nurse every day, twice a day for the first 5 days, and then once a day for the next 5 days. So for the first 10 days after surgery, even though you were at home, you had a nurse come and see you. And as well, you had you had blood tests done on day 1, 3, and 7. So this might be feasible within kind of a specific study setting, or maybe in France, but we're really within the North American context. This is basically like, you can throw this out the window. This is not going to happen. So even though for them, of 157 patients, they had what they called an uneventful outcome, which is pretty much patients who were able to go home from the recovery room on day 0 and did not have any complications and requiring ED visits or readmissions, about 74%. So they called this a very safe and feasible ambulatory colectomy. But again, their protocol required significant outpatient resources, which really are not available elsewhere. So we kind of based our protocol a bit and our inclusion-exclusion criteria on kind of very similar to the French study. And the main difference being is that we really wanted everyone to have a smartphone, because it was important that we felt it very important they used the app. Kind of when we did our feasibility study, the main outcome was the ED visits within the first 72 hours, because we wanted to make sure that these patients would not come back to the hospital during the time they would have otherwise stayed. And then we had kind of a safety stopping criteria just in case this would be too much. All right, our discharge criteria. So patients, in order to be discharged on day 0, so from the recovery room, they had to be tolerating PO intakes, which we defined of at least 300 cc's of fluids. And this was, again, based on the data that I showed previously. They would only be able to go if the pain was adequately controlled with oral analgesia, again, using tap locks and things like that we had talked about. They were able to pee because you got to pee, and they were able to walk around because you got to walk around to be able to go home. Our very first patient was done in February 2020. It was a 7-year-old guy, had a lap right colectomy for cancer, and his operation took 93 minutes, stayed in the recovery room for 7 hours. Given that, because this patient was our very, very first one, we really, really, really wanted to make sure that he was going to be okay before we sent him home. And kind of starting from February 2020, we had about 1 patient per week kind of trucking along. And then this little thing called COVID-19 happened and kind of put a wrench in a lot of research, but actually kind of helped us, if you look at it in that manner, for this particular study. So you all may or may not be aware, when COVID happened, especially in the very first couple, like 1 or 2 waves, when we didn't really know what the hell was going on, we had a lot of elective surgery cancellations, right? Because we wanted to make sure that we had hospital capacity in case we had this surge in COVID cases. And in certain parts that actually did happen. So a lot of patients who would have had elective surgeries really didn't during the early parts of 2020, and probably still to this day still happen. But that offered a unique opportunity for us, right? Because in COVID, there was really no hospital beds, because for a variety of either kind of because we wanted to maintain hospital capacity, or actually because our hospitals were full. And patients themselves didn't want to be in the hospital because they were afraid of catching COVID. And as well, we also knew that patients who caught COVID while in hospital had a very high mortality. So kind of in this little Venn diagram, this is where ambulatory colectomy really was very useful, because there were no beds, so patients couldn't stay, and patients didn't want to stay. So ambulatory colectomy, or kind of same-day discharge, was a really good response to this. So as Yogi Berra once said, if you know what Yogi Berra is, kind of this is one of his yogiisms, is when you come to a fork in the road, you got to take it. All right. So our same-day discharge protocol kind of trucked along over the entire kind of COVID pandemic. We actually were able to recruit quite a lot of people during the first couple months of the pandemic, because that was really the only way people were able to have their surgery, to be quite honest with you. So in the first kind of 6 months, We recruited about 40 patients, and we had a success rate around 77%. Again, kind of talking about using the same criteria as that French study of people actually leaving on day 0 and not coming back to the hospital in the first 3 days. Now we kind of updated our data, and this is up until the end of September of this year. We had about 200 potentially eligible procedures, right? Because again, I didn't go into too much detail about this, but not everyone's able to get this. So people who have a stoma, people who have open surgeries, some of the more complex cases we can't really send them home on day 0. That's not feasible or realistic. So out of around 200 patients who were potentially able to have that, 89 were ultimately recruited as same-day discharge, and some people we just weren't able to actually approach to ask them, and some people had to be excluded for a variety of reasons. So of these 89 patients, the average age was about 60, which is kind of pretty standard. 40% were male, 50% had cancer surgery, 14% had a rectal resection, which is important for us because that tends to be a bit more complex. So we were even able to do this in the slightly higher acuity surgery. Our mean procedure time was about 2 hours and change, which is pretty standard. And patients tend to stay in PACU for about 5-ish hours, so 320 minutes, give or take. All right, so obviously some people stay very short, some people stay very long, but on average around 5-ish hours. So of the 89 patients that we recruited for same-day discharge, 72 actually went home from the recovery room after. You're going to have some people who during their operation things change or they have complications, so we're not actually able to send them. And then we had 9 patients who failed our discharge criteria, which I showed you before, and actually had to be readmitted. Of all these people who had to be admitted after surgery, their average length of stay was only 1 day. So even though they had to stay, we were still mostly able to send them home the very next day. There was only 3% of people, so really just 2 people, 2 patients who had to go to the emergency room within the first 3 days, one of which had bleeding per rectum, which we really didn't do anything for, and we just watched for 1 day. And then another person came for pain that we couldn't find a cause and everything was normal, so we kind of just sent him home and didn't do anything. Patients really liked going home after surgery. So you can see here we did a satisfaction survey, and 80% disagreed with the statement that they should have stayed in hospital, and about 80, and the rest, and kind of subsequently also meant that 80% felt ready to go home, and they were able to manage their concerns and symptoms using the phone app, and probably would choose to go home again if had to go through if they had to go through their surgery all over again. So in summary, I showed that outpatient colectomy is safe and feasible in very select patients. And this is mainly because GI recovery is mostly uncomplicated. Pain can be well controlled with very little opioids, and remote post-discharge monitoring using a phone app is very effective. We hope that outpatient colectomy can reduce inpatient burden and unnecessary healthcare resource utilization. And in the context of kind of bed shortages within this pandemic, and really kind of throughout, even after the pandemic, we hope that this will minimize cancellations due to hospital capacity. And importantly, a lot of these principles can be applied to other procedures with short target length of stay. So right now, we've started doing a same-day discharge for sleeve gastrectomy for bariatric surgery, and thoracic surgery for vasulopectomy, which is exciting for us. So thank you for kind of listening to me ramble on. I know I talked a lot, and happy to answer any questions.
Thank you very much, Dr. Lee. Any questions? Please just unmute. So, Dr. Lee, do you have any prepare the patients preoperatively as well in order to have a faster recovery so that they could go home?
I mean, a lot of times it's really just setting patient expectations, right? So if you tell someone they're going to go home and they're going to do fine, they're going to go home and do fine. And, versus if you tell them, oh yeah, you got to stay 5 days and it's going to suck. And yeah, and like that's how their experience is going to be framed. So it's a lot of this actually is just about setting patient expectations and patient education, even before they go anywhere near the operating room. The truth, it sounds like we made these like a ton of these changes and so we were like, modifying and doing all these crazy new things. But in reality, when we started our outpatient protocol, like basically the only difference was that instead of admitting them, we sent them home on days, like from the recovery room. There was no changes to our actual enhanced recovery pathway in terms of what they did before surgery or during surgery, other than kind of the tap lock like I talked about. But everything else was the same. And the only difference is that we kind of just told people like, you're going to go home on day 0. And they're like, okay. And that was it. And now people, yeah, they're always a little bit surprised because they're like, oh yeah, my mom had surgery and they stayed in hospital for like 95 days. But you can usually tell them that, things have gotten a lot better in the last 20 years.
Yeah. So if I smoke or I drink alcohol, would you recommend that then that I stop before surgery? Does that have any effect on the outcome?
Yeah, I mean, definitely. So, there is still going to be preoperative optimization, but that tends to be kind of true for anything you do, right? So if you, regardless what operation you had, we would tell you to stop smoking and stop drinking. There's going to be some procedures that you have the luxury of time, right? So if you're going to go in for surgery for some sort of benign condition, if you smoke and drink, we might wait until you stop smoking and stop drinking to operate on you. Versus if you have cancer, kind of like I'm a cancer surgeon, so I don't tend to have that luxury of like waiting until patients are absolutely totally maximized or optimized for surgery, because cancer we can't necessarily wait super long for that. But again, the same principles tend to apply for regular inpatient surgery versus same day discharge. Obviously, the healthier patients tend to do well. And we kind of select out the healthier patients, obviously, but otherwise the rest shouldn't change all that much.
Okay. Any questions? Do we have questions in the chat?
I would like to ask a question, please. So Dr. Lee, that was a great, fantastic presentation. Thank you so much. I'm not a surgeon, but I did have one question regarding the difference between undergoing your enhanced recovery program with elective surgeries versus, say, emergent surgeries. How well can you translate from one to the other? Saying how well can the majority of your program that you're building be translated or be applied, or what sections can be applied the most for, say, surgeries that are a bit more extensive or have poor outcomes generally?
So that's actually a big kind of discussion point amongst experts down in the literature, in that we always tend to still be a little bit more conservative in the emergency patients, right? But there's an emergency and then there's an emergency, right? So it's not necessarily one size fits all, right? So if you have, there are going to be some cases done emergently that we can essentially treat exactly the same as an elective procedure, right? So whatever, I can't think of, let's say if you have a perforated diverticulitis without significant spillage, but has peritonitis, and you go and you do a primary anastomosis without doing a stoba, you do the whole thing laparoscopically, yeah, that patient probably stays 1 to 2 days. Obviously some of the preoperative interventions that we do, like optimization, carbohydrate loading, like, you're not going to be able to do for obvious reasons, but a lot of the intraoperative and the postoperative stuff stays the same. Like, we're still able to do. Now there's that versus like some dude who comes in with like ischemic colon and who's near death, and then like, arrests a couple of times on the table. Like, there's going to be, you got to select patients a little bit, but as much as possible, we do know that, there are studies showing that a lot of the principles can be applied even in the slightly more kind of acute, and the acute patients are the ones that are physiologically sicker. But again, it's like very hard to interpret some of that data, right? Because again, there's like an emergency and then there's an emergency. So
that makes a lot of sense. Thanks a lot.
So when you compare the pivot towards NSAID it does make sense, of course, to the whole crisis with opioids. Now, when you compare between the sort of results you obtain, when opioid were so-called en vogue, compared to the new protocols that how do they compare?
Well, in what sense? What do you mean what they compare? I mean, basically try not to give opioids to anybody anymore.
Right.
Because, there's tons of data basically just showing opioids are bad. And truth be told, if opioids were introduced now, they probably wouldn't pass FDA and Health Canada approvals because of all the side effects that they have. And I'm sure everyone's heard in the news about the opioid crisis, yada, 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 right? And again, a lot of it, to be honest, again, it comes back to setting patient expectations. It wasn't that long ago. So when I was a medical student, our goal was zero pain after surgery, right? So we would load patients up with opioids to make sure their pain level was 0 on 10. But that's probably unrealistic, right? If we cut you, you have an incision, it's supposed to hurt a little bit. It's normal for it to hurt a little bit. And so now the way we counsel patients is that we tell them that a little bit of pain is normal and it just has to be tolerable, right? We can make everyone pain level 0. We could do it, but is that going to be actually helpful for them because of the type of the amount of medications and opioids that we have to give to reach that? And what is the actual benefit of pain level 0 versus a pain level of 2 or 3, and not having to give any opioids? So a lot of it is patient expectations. Again, telling them a little bit of pain is normal.
Right.
And kind of using a lot of these adjuncts that I talked about, like Taplock, Sensaids, Tylenol around the clock. These things actually work super well. And increasingly, we don't have to give opioids to people. So I didn't go through the data, but in our same day discharge protocol, we send patients home only with 5 tablets of oxycodone, which is which is one type of opioid. And in the 79, I don't know how the 79 odd patients that have been sent home, not a single one has required more than 5 tabs. And the vast majority of them actually don't use any of it at all. Which again, if you think about if I had showed you this data 10 years ago, your mind would be blown because we were giving people tons and tons of opioids, but now we have tons and tons of people who are addicted. And
Right.
that's kind of the reason why we have this opioid crisis.
So would you recommend administering NSAIDs before surgery to enhance analgesia?
Yeah, we do that actually now. That is part of it, is that there's a lot of kind of preoperative medications that we give to try to kind of or minimize the pain impact. And part of it is actually this Taplock. It's done while they're still under anesthesia. So the idea is that when they wake up, they're not screaming in pain because the anesthesia has worn off, and they actually have kind of this other multimodal effect, so that their pain level, we can keep on top of their pain level at a bearable manner, instead of we wake you up cold turkey and you have a 10 on 10 pain, and then we gotta kind of rescue you with tons of opioids, and then we conk you out, and then so forth. It's all synergistic. It's not just one particular thing that we do that makes it better. And I think that's the idea of a lot of these enhanced recovery protocols, is that each small little intervention, when you put them all together, has this huge effect.
Right. So there is a question in the chat from Jeremy Zweig, and says, thank you, Dr. Lee. Were average cost savings calculated while using this protocol as compared to the previous standard of care?
So when you look at kind of standard, enhanced recovery versus conventional care, the average cost savings is about $2,000, give or take. But again, you always got to take that with a little bit of grain of salt, because it's very healthcare system dependent. So $2,000 in Canada is a big deal, but $2,000 in the US is I don't know, they use one less roll of toilet paper or something like that, right? So you gotta take all these things in a little bit of context. There have been multiple economic evaluations, and the vast majority of them have shown an improvement in cost savings in favor of enhanced recovery. But again, that really depends on the context, right? So like I said, we save $2,000 in Canada, that's a huge amount. But in the US, probably not so much. But the magnitude of difference is going to be much higher. Now, if you look at same day surgery versus enhanced recovery, kind of quote unquote standard enhanced recovery, we're in the process of doing that now. I suspect that it'll still be, there will be some amount, but I don't think it'll be that much, to be quite honest, because the main thing that you're saving is going to be just like 1 or 2 days hotel cost. And a day in hospital is around $600, give or take, in Canada, or at least in Quebec. So you can kind of do the math there. But also don't forget that it does cost something to have the app.
Right.
Not much, but it costs something.
Right. So any further questions? So if there are no questions, I would like to thank Dr. Lee for this wonderful presentation. I would like to thank everyone for attending this seminar. Very much appreciated. So thank you very much, everyone.
Great, thank you.
Thank you. All right.